Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from ARS Pharma.
Hi, I'm Matt Greenhot, Professor of Pediatrics in the Section of Allergy and Immunology at Children's Hospital Colorado and the University of Colorado School of Medicine in Aurora, Colorado. Welcome to this program titled Innovations and Breakthroughs in Epinephrine Delivery, Optimizing Outcomes with Early Intervention for Anaphylaxis. Joining me today is my colleague and good friend, Jay Lieberman, professor at the College of Medicine, Memphis, in the Department of Pediatrics at the University of Tennessee Health Science Center in Memphis, Tennessee. Welcome, Jay.
Hey, Matt, how are you?
I'm good. All right, so let's dive into the material today because we have an ambitious agenda. So we're going to talk about anaphylaxis. So for those of you who are unfamiliar, anaphylaxis is a severe life-threatening allergic reaction involving multiple organ systems. This is something that we as allergists really strive to educate our patients should be treated immediately. The more rapidly that this is treated, the better the outcomes are. The best choice of treatment for anaphylaxis is epinephrine. This is the most efficient drug that you're going to find to sort of treat across all organ systems. And it's the first-line treatment in anaphylaxis management, mainly because of its superior outcomes in terms of affecting cardiac and respiratory physiology. Anaphylaxis can be quite unpredictable in terms of its clinical course. Jay, I'm sure you've seen this too, in when we, as part of our jobs, actually provoke allergic reactions as part of food challenges and drug challenges and whatnot. But this is something that can progress quite rapidly right before your eyes, faster than you might realize. With this, the burden of severe reactions and the impact they have on patient-related health can be quite concerning. Anaphylaxis is one of these things that can actually worsen food allergy quality of life. And really, in all that we do in terms of educating our patients as well as the community and other other physicians and healthcare providers who might be in the chain of treatment, is that we want to treat this as early in the chain of symptoms as possible before it gets to a point where the symptoms are so severe that you're needing sort of advanced medication and resuscitation. Studies have shown that early use of epinephrine is associated with improved outcomes. This can lower the rates of hospitalization, it can shorter the length of stay in emergency departments, and then decrease the likelihood of hospitalization. Patients who aren't treated may be at an increased risk of biphasic reactions. They certainly can suffer morbidity in terms of abnormal vital signs, need more interventions. And this is why we universally prepare anybody at risk for anaphylaxis to always have a source of epinephrine with them. And traditionally, this has been the epinephrine autoinjector. These are very portable, very easy to carry devices, but data have shown a little bit of a disappointing trend that these are underutilized by both patients and medical teams. Up to 50% of adults don't use their epinephrine autoinjector. So in terms of that, Jay, what do you think some of the factors are that might impact the use of epinephrine in any form, in particular autoinjectors?
Yeah, Matt, I mean, you said it like you said, when you're doing a challenge or something in the clinic, and a patient's undergoing an acute allergic reaction, it can be kind of hectic, and you're well versed in treatment. So you can only imagine what this is like for our patients at home that are not medically trained. That's the beauty of the autoinjector. It has provided our patients with a very portable, you could argue easy to use device to treat these allergic reactions. Unfortunately, there's still room for improvement. Like you said, a lot of our patients don't use their autoinjectors, and there's a number of reasons for that, right? It brings up kind of that Swiss cheese model where you have multiple possible things that could go wrong, leading to errors or lack of use. And any one of those steps along the way can lead to decreased use of epinephrine. So what could those include? Things like, just simple fear of needles. As you said, what we have available to us today for our patients is autoinjectors, But that means that the patient has to inject themselves. And there's a lot of fear, not only amongst pediatric patients, obviously, but even some adults who are concerned about the use of a needle. The other part is the stigma of the medication itself. So while epinephrine is a natural chemical in our body and shouldn't evoke, fears or concerns, it does carry the stigma that I think, patients, or at least in my practice, I see patients have a little bit of a fear, like I am going to do something harmful when I inject this crazy, epinephrine into my body, which isn't true at all. Other things that can hinder use is kind of this unsure if they're having the allergic reaction that's severe enough. Like, when do I use it? We provide our patients with anaphylaxis action plans, which in some studies have been shown to increase use of epinephrine, but there's still a lot of hesitancy, uncertainty, like, is this enough to use it? Should I use it now? What's the symptom I need to be on the lookout for? Lastly is, even if you get over those hurdles, meaning you're accepting the needle, you know when to use it, you still have problems such as incorrect technique. Every year there's a large number of people who try to administer to the patient, and they actually administer in their own thumb, and because of the device is backward or something like that. We always ask our patients to carry 2 in case they need a second dose, and that's a lot of patients don't even carry 1, much less 2. And lastly, there's access to device. In the United States, we have the availability of auto injectors, but in a lot of countries, they don't even have the auto injectors. And once you get them, the shelf life is around a year. So there's some issues with storage, with the shelf life, and high temperature excursions, high heat or very cold, which affect the auto injector. So all of these factors go in together and cause this problem where we have, like you said, low carriage rates or low usage rates of epinephrine for anaphylaxis.
Yeah, I mean, you raised some good points. I can't remember the last day in clinic where I didn't sort of explain that Swiss cheese model to patients and whatnot. And really, that's been such a good teaching tool moving forward. The fear of needles, it's not just epinephrine. I mean, there are many other. There are problems with receiving other forms of medication, including vaccines, that spill over from this fear of needles, and it's quite rampant, not only in children but in some adults. The other thing is that supply chain. We've seen 2 disruptions in the past 10 years alone, where patients have not been able to get auto injectors. So there are a number of barriers. I mean, if they can't even buy it, then they're not going to be able to carry it. So we know that there are many barriers with injectable epinephrine forms. And this has sort of spurned an innovation within the anaphylaxis treatment space to help sort of look at ways that we could increase carriage of devices and maybe even develop new forms of delivery. So let's talk about some of the novel approaches. So right on the heels of the end of the summer, we had the approval of a new intranasal spray, which is the newest form of epinephrine that's been approved. Jay, what can you tell us about this therapy?
Yeah, like you said, it was approved both in the United States and the European Union in third quarter 2024. So brand new approval. So what it is, it's a nasal spray, and the device has essentially been used in the United States to treat other conditions such as using naloxone in this device for opioid overdose, or using diazepam in the same device to treat seizures. So the device itself has been used for similar type conditions, and now it's been studied and approved to treat anaphylaxis or severe type 1 allergic reaction. Currently, it's approved for that indication in adults and pediatric patients who weigh greater than 30 kilograms or about 66 pounds. The way it comes is a no spray device that contains 1 dose in each device, which is a 2 milligram dose of epinephrine. So the prescription is for a 2-pack, just like our auto injectors, and it would come with 2 nasal spray devices. Each device is 1 dose, 2 milligrams, delivered into 1 nostril. And if the patient is not better within, a few minutes, 5 to 10 minutes, it's recommended to give the second dose into the same nostril.
Okay, Jay, so we've got this spray. You can administer epinephrine up your nose, but how does this work? Can you explain a little bit about sort of what this chemical does and how it gets into the system?
Yeah, well, I mean, obviously, any way to get epinephrine in the bloodstream to the target tissue is what we want, however that works. So intranasally, this could be done. There's a large vasculature there. As we discussed, it's been used in other conditions that are acute medical conditions like opioid overdose. So, it's a good model for that. What this device does is it adds an ingredient, a proprietary ingredient, an alkyl saccharide that allows for increased absorption into that nasal cavity where you've got a large vasculature. It can then go directly into bloodstream. It can bypass first pass metabolism so that you get direct epinephrine right into the bloodstream very quickly.
All right. So, what do you know about some of the data in terms of its use? Can you talk about sort of some of the studies that helped lead to the approval?
Yeah, I mean, first of all, I think it's important to understand how approval of auto injectors, which we're all comfortable with, how that got through approval through regulatory agencies. So auto injectors were approved based on pharmacokinetics, meaning can they establish epinephrine concentrations in the bloodstream that were similar to if you just inject epinephrine with a needle and syringe. And so the nasal spray epinephrine utilized that same exact pathway. So meaning they had to prove that they could achieve levels of epinephrine in the bloodstream that were very similar to whether you injected it with a syringe and needle or whether you injected it with an auto injector. And so they performed multiple studies, over 4 studies in 175 healthy adults without anaphylaxis as their main study. And what they showed is that they could achieve concentrations in the bloodstream of epinephrine that were very similar. So essentially, the long and short of it is that they could achieve max concentration, time to max concentration, an area under the curve, or the total exposure to epinephrine, that were essentially between if you injected epinephrine with a syringe and needle and if you used the auto injector. And that's kind of how it gained approval by showing that. In addition, they also had to show that the pharmacodynamics, meaning changes in things like blood pressure, heart rate, were similar to the devices that are currently available. And they showed very similar changes in that regard. In fact, they showed a slight increase in diastolic blood pressure changes as compared to auto injectors, which you could argue may be clinically relevant.
Yeah, looking at these data, that's the one thing that struck me in terms of sort of that diastolic effect, and that some of that is based on sort of the volume and concentration that passes by certain receptors or whatnot. But it was pretty clear that you see this dip with the injectable forms that you're not seeing with this particular nasal spray, which is good. Yeah, I mean, one of the things that I've been hearing a lot is sort of, well, this hasn't been tested in humans or whatnot. And that's not accurate. I mean, you're talking about epinephrine. You can't exactly put somebody into anaphylaxis and test response. Those are not considered ethical experiments, at least in this country. And this is the way that all of these forms of epinephrine, even the things that we're saying are completely reliable or whatnot. And I think people sort of forget that they're seeing something new, and that natural sort of potential distrust of, well, I don't like how these studies were done. And so this is what you're going to see in the entire epinephrine space, not only for this approved product, but for 2 other forms that we're going to discuss a little later in this talk. These are the types of studies that can be done. All right. So these were the adult data. What about pediatric studies? What do you know about those?
Yeah, the pediatric studies are ongoing, but obviously, you have to remember that it is approved for patients greater than 30 kilograms, which will include a lot of pediatric patients. I mean, when you think about it, the average 8 to 11-year-old in the United States probably is where you switch them over to if they're on an auto injector, where you switch them over to the adult auto injector device. So even though we don't have full approval for less than 30 kilograms yet, and we hope to in the future for this device, but we do have the ability to use it in pediatric and adolescent patients who are over that 30 kilogram threshold.
Yeah, that's an important point that it's the weight, not necessarily the age. All right, we're talking about a nasal spray for this form of epinephrine. And you're talking about a patient, and a patient type that often have other allergic issues. So, what do you do if you've got an upper respiratory tract infection, or somebody who, and I'm feeling it today, is it's just sort of teetering above freezing, and my mold allergy is going crazy. What about nasal congestion, either from allergen exposure or from an infection? Is this going to have less efficacy?
Yeah, I mean, it gets back to your point earlier about, this is the data that we have, but it's not like all we have is data in healthy patients. Obviously, the regulatory agencies did require a little more data before approval of the nasal device. So, for example, they required a nasal allergen challenge study, meaning, okay, if we're concerned that during anaphylaxis, maybe a patient has a lot of congestion, rhinorrhea, we need to know what the absorption is in that state. So um, prior to approval, they did a study in patients who had allergic rhinitis, like you were talking about with your mold allergy. Let's say the patient's allergic to dust. They exposed the patient to dust, but they checked epinephrine concentrations with the device both before giving them the dust allergen challenge and after. And it was fascinating. What they actually showed is that you got a quicker uptake of epinephrine and higher concentrations quickly in the bloodstream in the nasal allergen challenge model. And it was kind of counterintuitive to me. I thought, oh, all that congestion, all that mucus is just going to block the epinephrine from getting absorbed. But actually, the vasodilation during an allergic reaction caused a faster absorption of epinephrine, which, once again, you could argue may be a better thing, that if you're having runny nose during an allergic reaction and I can get that epinephrine in even quicker, maybe that's a good thing. They also studied, like you're talking about, an upper respiratory tract infection model, meaning when patients had an upper respiratory tract infection, they gave them the nasal device and then they gave it to them when they were otherwise healthy, and showed there was really no change in absorption in that model.
Yeah. Um, what would you say? What would you advise a patient who had maybe some sinus surgery, sort of a nasal window, or has a chronic nasal polyps? What about use of this drug in those types of patients?
Yeah, it's a great point. There is, in the package insert, it does say this has not been studied in patients with things like nasal surgery, nasal polyps. Perhaps these are patients that will have altered absorption, and since it hasn't been studied in those minority of patients, maybe this device, may not be the epinephrine device for them. Maybe we'll have studies in the future, but for now, that we don't know the absorption in those patients.
Gotcha. All right. What about just some other issues? So, in terms of side effects, adverse events, how would you counsel a patient who asks, like, well, I know what's going to happen if I use a needle. It's going to hurt, and but what if I put this stuff up my nose now? What am I going to feel?
Yeah, so most in the published studies to date, the side effect profile was pretty mild. They do get some throat irritation, some paresthesia in the nose, so kind of like numbness in the nose, a little headache, nasal discomfort. But those are the main side effects that were seen above placebo with this device. No serious adverse events, in the nasal device group. So overall, pretty safe.
So we've talked about this new option, but what else is in the pipeline in terms of alternative forms? And say maybe you don't want to put something up your nose. What other choices do you have in terms of epinephrine development?
Yeah, so for those of us who have followed this space, for years, originally the alternative form was going to be a sublingual tablet that was studied early on, and then that kind of fell away. But now we do have some forms that are being studied. The one furthest along after the intranasal device is a sublingual film. So this is a proprietary film, and you can think of it just like the old mouthwash strips that you would put in your mouth and it just kind of dissolves. It's the same idea as this polymer matrix-based epinephrine prodrug. And I mentioned the prodrug just because epinephrine is a vasoconstrictor, so you have to be able to get it delivered into the vasculature in this case, as a prodrug. And then it gets metabolized to epinephrine very quickly in the bloodstream. You don't have first pass metabolism, so you don't have to worry. It doesn't go to the kidney first, but is activated right away. and active in the bloodstream.
You make a great point about sort of the use of the prodrug because, many out there who work in healthcare, if you've ever sutured somebody, you put epinephrine in that wound, except in sort of distal extremities or whatnot, to help control the bleeding. So you do get that vasoconstriction, which just goes to show you, based on where you're putting it, you might need to sort of outsmart the body system. So that's why this drug has a use of a prodrug. All right. So what about some of the early data on this, Jay? What can you tell us?
Yeah, I mean, it's very similar to the intranasal device in that the studies that have been published to date are showing that they can achieve the same idea, meaning achieve plasma epinephrine concentrations that are in line, or at least in between, if I were to inject epinephrine with a needle syringe and if I were to use one of the auto injectors that's available on the market. So very similar max concentration, time to max concentration, and area under the curve for total exposure to epinephrine. Once again, with just like the nasal device, the pharmacodynamics were similar as well, changes in systolic blood pressure and heart rate. But once again, you are seeing this slight change in diastolic blood pressure changes after administration with a non-injectable route. So it'll be interesting to keep an eye on that.
Yep. And again, it goes back. I'm not sure if we use this word, but the FDA calls it bracketing, basically between the auto injector and either the subcutaneous in some of these experiments or the intermuscular injection with the needle and plunge. So another product that just sort of has to. Yesterday was Sunday, right? It's just like kicking it right between the goalposts. That's what the FDA is looking for. And in terms of safety, any like, in terms of side effects or whatnot, in terms of, at the therapeutic dose, anything you can comment on about that in these early data?
Yeah, so far in the published data, the side effect profile was very mild.
And then, we talked about with the nasal application. So like, what if you got a runny nose? How about this one? Like, what if your kid just, ate a peanut butter sandwich and there's a bunch of greasy, oily food or whatnot in there? Can you still use this?
Yeah, no, it's a great point. The regulatory agencies did ask for them to do studies in a similar model, and they've actually have a study in which they have patients, eat something like a peanut butter and jelly sandwich, and then dose with the device. And so far, they've showed that it's really not much difference whether there was still some food residue in the mouth. Really, no relative impact on the pharmacokinetics or the pharmacodynamics of this device in that model.
Right. And what about slippage or whatnot, right? I believe there were data that also suggested that, while you want it under the tongue, if it slipped over to the side, what did that show?
Yeah, the most recent one that was presented at the college meeting that you were just referring to showed that it didn't really matter if it, the patch may have slipped or migrated a little bit in the mouth. As long as it was in the sublingual space, you had similar absorption than if it stayed in one place.
So that's fantastic. So I applaud both companies in terms of sort of understanding the human use factors and where people may have doubt that, based on what might be plugging up your nose or sort of coating your mouth, that you're getting sort of the same levels and you're meeting the FDA standards. So hopefully that's reassuring. As a prescriber, to me, that's reassuring. That's really all I need.
Well, Matt, you keep up with this too. There are other nasal devices, right?
There are. Yeah. So there's one that's all still in development. This one, the dose for this one that they're looking at is 13.2 milligrams. But this one is delivered by 2 sprays. So each spray is 6.6. And they looked at, a pooled data set from 4 open label phase 1 crossover studies in healthy adults, very similar to the other 2 designs that we just talked about. Looking at this either into the same or the opposite nostril. So you're getting either, here, 2 here, or 1 across, compared to either the IM dose or the auto-injector, but at 0.3. And what this showed was similar to the data that, again, it's hitting the bracket. You see that with the nasal spray, you see an increased epinephrine plasma concentration, where the levels are either greater or more sustained than the auto-injector. And again, you're seeing similar pharmacodynamic effects on heart rate and blood pressure among the 3 treatment groups that were studied in this compared to the effects with the auto-injectors. So similar data. Again, this is a common FDA standard that everybody has to meet. So we have 3 forms of epinephrine, 2 nasal forms, and 1 sublingual form, all sort of representing novel administration routes. Some of the data has shown that in terms of the pharmacokinetics and the pharmacodynamics, that these should work exactly the same as the injectable forms. And actually, if you look at some of these data, they might even work a little bit faster or a little bit better in terms of response that you're seeing. So what would you have a patient sitting in front of you, right? And they're like, I'm thinking of, potentially switching. I don't like carrying my device anymore. I'm looking for something new. Can you sell me on this? What are some things that I'm going to get? What are some advantages of some of these new forms in terms of, how's this going to help me? What would you say to a patient like that?
Yeah, I would say to a patient where we are fortunate to have more than one route now, and it's a shared decision-making process. Go over the data with them, explain what it was, and if they're comfortable with that, I'm personally comfortable prescribing it for my patients. As always, with the new forms, just like with the old forms, we have to remember to tell our patients, if you use it and you're not getting better, remember to activate emergency medical services or call 911 or go to the emergency room if not improving, just like we would with our injectable form. And so there's a shared decision-making component, but there's also treating it just like we would our injectable forms.
Yeah, I think that's an important thing, is both of us were authors on the recent anaphylaxis practice parameter update. That is something that is evolving, where patients in certain contexts have the choice that if they feel that there's a response after using epinephrine, and it doesn't matter which form, that you don't automatically have to just call 911 or go to the emergency room. You can watch and wait for a response. And obviously, there's some limits to that. If they're not improving within 5 to 15 minutes, then that's when a second dose might be indicated. But that is a change, and that's something that can sort of help evolve things in terms of these new forms, where in the prescribing information for this newly approved nasal form, it does not discuss going to the emergency room in these settings. So that's sort of an advantage. What about shelf life? Can you comment on that in terms of how this might also be an additional innovation?
Yeah, so the nasal device appears to have a little bit longer shelf life, so approaching more like 2 years to almost 36 months in some circumstances. And the other nice thing is that, per the manufacturer's statement, it has a larger temperature excursion, so you don't have to worry as much if it's in the hot car or in next to something cold, or in the car on a cold day. So the shelf life's a little longer than the currently available products, and the temperature excursion is wider than the currently available auto-injectors. So that's a nice touch as well.
What would you tell somebody who is hesitant to switch?
Yeah, it's a personal preference, both from the clinician and the patient. I believe that if epinephrine works, that these data suggest that this product will work. So that's how I view it. But I will offer it to my patient and trust, and believe in their comfort level. If they want to try it, no problem, in my opinion. If they're a patient who's a little hesitant because they just feel better with the auto injector, that's their choice as well.
Yeah, no, I agree. The one thing that I've already talked to some patients about is sort of the approval path, to help them understand that, epinephrine devices are approved in a very particular way, and it's different than a cardiac drug or, the latest food allergy treatment, and just sort of getting them used to that. But reassuring them that the FDA is watching this, especially why you use this drug. It's supposed to be life-saving. They're not going to put anything out there on the market that they don't feel is going to work. So, but like everybody, you see hesitation to switch to new technologies. People agonize over sort of the latest smartphone upgrade each year. So Everybody has their sort of decision points about that, but these are shared decisions that you should be able to help support your patient and give them, the information and the facts for them to sort of work through what they might need to come to one decision or the other, and for us to just sort of step back. I mean, I think getting patients talking about new forms of epinephrine, to me, that means that they actually want to carry it, which is great. So they're solving a problem for me. I worry very much that they actually don't have it. So these are great discussions for me, and it alleviates a lot of concerns. So,
Agreed.
anyways, Jay, any other points? Anything else you want to emphasize?
No, I think that was a really nice discussion.
Yeah, thanks, Jay. I really appreciate you taking the time to help sort of work through this with me. We'd like to also, both of us, thank the audience for their participation in this activity. If you please continue on to answer the questions that follow and complete the evaluation, we would greatly appreciate that.